Hello, how are you today? Today our topic is acute pulmonary embolism. So I am Dr. Parvez Ahmad Rishi. Let us get started. Definition: it is blockage of pulmonary arteries by a dislodged thrombi, fat, air embolism, tumor tissue with subsequent obstruction of blood supply to the lung parenchyma. Predisposing factors for venous thromboembolism: strong risk factors, fracture of lower limb, hospitalization for heart failure or atrial fibrillation within previous 3 months, hip fracture of hip or knee replacement, major trauma, MI within previous 3 months, previous venous thromboembolism, spinal cord injury. All these issues contribute to, these are strong risk factors. Then we have moderate risk factors. Moderate risk factors are the moderate risk factors are autoimmune disease, arthroscopic knee injury, blood transfusion, central venous line, chemotherapy, congestive heart failure, respiratory failure, erythropoiesis, stimulating agents, HRT, infections like pneumonia, and we have inflammatory bowel disease, cancer, high risk in metastatic disease, oral contraceptive therapy, paralytic shock, postpartum period, superficial venous thrombosis, and thrombophilia. These are moderate risk factors. Weak risk factors are bed rest, more than 3 days, diabetes mellitus, hypertension, immobility due to prolonged sitting, increased age, laparoscopic surgeries, obesity, pregnancy, and varicose veins. Initial risk stratification of acute pulmonary embolism. Suspected acute pulmonary embolism. So if we suspect acute pulmonary embolism, there is shock or hypotension. If there is shock or hypotension, this is high risk. If there is no shock or hypotension, this is not high risk. Assessment of pretest probability. So we have previous pulmonary embolism or DVT. In the original version of the scale, clinical decision rule point, it was 1.5. And now we have the simplified version where everything is 1. We have heart rate more than 100, so score is 1. Surgery or immobilization with past 4 weeks, hemolysis, active cancer, clinical signs of DVT, alternative diagnosis less likely than pulmonary embolism. So score of everything is 1. Then we calculate that score, and here score of some parts is 3 and some of some elements is 1.5. Now it has been simplified. So 3 level scores are: low is 0 to 1, intermediate is 2 to 6, and high is greater than 7. 2 level score, original version simplified. Pulmonary embolism is unlikely 0 to 4, 0 to 1. Pulmonary embolism is likely, it is greater than 5 or it is greater than 2. So in the simplified scale, if pulmonary embolism is, if the score is 0 to 1, it is unlikely, that is, there is no such thing. And if it is greater than 2, then the pulmonary embolism may be there. It is likely that the pulmonary embolism has occurred. Okay. Diagnostic algorithm: not high risk versus risk pulmonary embolism. So we have suspected pulmonary embolism without shock or hypotension. Now we are taking a presumption that there is no hypotension, there is no shock. Assess clinical probability of pulmonary embolism, clinical judgment or prediction rule. So we have low intermediate clinical probability of pulmonary embolism is unlikely. We do D-dimer test. If it is positive, if it is negative, we don't give any treatment. If it is positive, we go for CT angiography. If it is no pulmonary embolism, so no treatment. If it is pulmonary embolism may be confirmed on CT angiography and we give treatment. High clinical probability of pulmonary embolism, we directly do CT angiography, we don't need to do D-dimer. If there is no, we give no treatment and investigate further, If there is pulmonary embolism confirmed, we give treatment. So there is only one point, D-dimer. D-dimer we give high clinical, low clinical suspicion. If there is high clinical suspicion, we skip D-dimer test. We save time. Now we have CT angiography and intermediate available, immediately available. Echocardiography, if we have suspected pulmonary embolism with shock or hypotension. If we have shock or hypotension, CT angiography immediately available. If it is not available, we do ECG. If it shows right ventricular overload. If it doesn't show right ventricular overload, we search for other causes or hemodynamic instability. If there is overload, we no other or antibiotics or patient unstable. If patient is unstable, we go for pulmonary embolism specific treatment, primary reperfusion, or we do CT angiography if it is available and patient stabilized. So if CT angiography is directly available in case of shock or hypoperfusion, we give CT angiography. If it is positive, we give the treatment. If it is negative, we search for other causes of hemodynamic instability. We have taken this diagram from www.escardio.org guidelines. We give full credit to them and don't hide anything. The diagnosis is suspected pulmonary embolism with shock or hypotension. Emergency CT angiography or bedside transthoracic echocardiography based on availability and clinical circumstances. If patient 2 is unstable, for CT, CUS, TOE may be considered. In case of unstable, patient is admitted to cath lab and coronary angiography excluded. ACS and pulmonary embolism emergency as probable diagnosis. Pulmonary angiography may be considered. Suspected pulmonary embolism without shock or hypotension. Clinical judgment D-dimer. Recommended inpatient emergency department in patients with low intermediate clinical probability. Reduce the need of unnecessary imaging and radiation. Low clinical probability, high or moderate sensitive assay. Intermediate probability, further testing with negative moderately sensitive assay. High clinical probability, D-dimer not recommended. CT angiography. Normal CT angiography safely excludes low, intermediate and high clinical probabilities. Finding segmental or more proximal thrombus confirms PE. In case of isolated subsegmental clots, further testing to confirm pulmonary embolism considered. Scintigraphy. Normal perfusion lung scintigram excludes PE. High probability V ventilation perfusion scan, VQ scan confirms it. Non-diagnostic VQ negatively CUS excludes pulmonary embolism in low clinical probability patients. Lower limb CUS. In search of DVT, lower limb CUS if positive can obviate imaging. If proximal DVT in CUS confirm pulmonary embolism. If distal DVT, go for further assessment. Pulmonary angiography. In case of discrepancies between clinical evaluation and imaging tests, MRA should not be used to rule out pulmonary embolism. Original and simplified pulmonary embolism severity index parameter, original version and simplified version. Male sex plus 10, 1 point. Age in years. It has no point. 1 point if age greater than 80. Cancer plus 30 years of age. It has 1 point. Simplified version. Chronic heart failure plus 10 age in years. We have 1 point. Chronic pulmonary disease 1 point. Pulse rate greater than 110 1 point. Systolic BP grade less than 100 1 point. It shows shock. Respiratory rate 30 breaths per minute. It is hyperventilating. No points for it. Temperature 1 point for it. Altered mental status 1 point for it. Altered oxyhemoglobin saturation 1 point for it. Risk strata. Original version. Class 1. It is greater than 65 points, very low mortality risk. Class 2nd, 68 to 85 points, low mortality risk. In simplified version, we have 0 points, mortality risk is 1%. Class 3rd is 86 to 105 points, moderate mortality risk. Class 4 is 106 125 point, high mortality risk. Class 5 is greater than 125 points, very high mortality risk. 1 point mortality risk 10.9%. Now we have risk adjusted management algorithm, clinical suspicion of pulmonary embolism, shock, hypotension, diagnostic algorithm as per suspected high risk pulmonary embolism, PE confirmed high risk primary reperfusion, diagnostic algorithm as for suspected not high risk pulmonary embolism, assess clinical risk PESE, SPESS. We have intermediate risk or we have low risk. For low risk, we don't give any treatment. Intermediate risk, right ventricular function, we assess right ventricular function by using laboratory tests. So if both are positive, it forms the intermediate risk. AC monitoring and consider rescue reperfusion. Intermediate low risk, ATC hospitalization, AIC and hospitalization. In low risk, we don't give any specific treatment. We have again taken the slide from this site. Thrombolytic treatment of pulmonary embolism. Streptokinase 250,000 international units loading dose over 30 minutes, followed by 1 lakh international units per hour over 12 to 24 hours. Urokinase 4,400 international units per kg, loading dose over 10 minutes, followed by 4,400 international units per kg per hour over 12 to 24 hours. According to registered 1.5 million international units over 2 hours, this streptokinase. Recombinant tissue plasminogen activator, 100 milligram over 2 hours, 0.06 milligram per kg over 15 minutes, maximum dose 50 milligram. Contraindications to thrombolysis. absolute contraindication, relative contraindication, hemorrhagic shock or stroke of unknown origin at any time. If there is history of stroke, hemorrhage, ischemic stroke in the preceding 6 months, CNS damage or neoplasm, recent major trauma, surgery, head injury in preceding 3 weeks, GI bleeding within last month, known bleeding risk, relative contraindications, TIA, transient ischemic attack in the preceding 6 months, oral anticoagulant therapy, pregnancy or within 1 week postpartum, non-compressible puncture site, traumatic resuscitation, refractory hypertension, advanced liver disease, infective endocarditis, active peptic ulcer. In these things, we don't give thrombolytic therapy. We don't do thrombolysis. Parenteral anticoagulation for pulmonary embolism. We have low molecular weight heparin and pentasaccharides, fludarabinus, and approved for treatment of pulmonary embolism. Enoxaparin, 1 milligram per kg or 1.5 milligram per kg every 12 hours once daily. Tinzaparin, 175 units per kg OD. Dalteparin, it is 100 international units per kg or 200 international units per kg every 12 hours. Nadroparin, it is 86 international units per kg every 12 hours. Fondaparinux, it is 5 milligram, less than 50 milligram total dose. 7.5 milligram, 50 to 100 kilogram. 10 milligram body weight greater than 100 kg. We give it OD. Acute phase treatment, high risk. Initial IV anticoagulation with UFH without delay. Thrombolytic therapy recommended. Surgical pulmonary embolectomy for patients in home thrombolysis contraindicated or failed. Percutaneous catheter dissected. Treatment. Consider alternative to SPE if full dose systemic thrombolysis failed. Indication intermediate or low risk. Combination of parenteral treatment with VKA. Low molecular weight heparin recommended. Partial treatment with VKA. Recommended targeting an INR 2.5. New oral anticoagulants rivaroxaban, apixaban, dabigatran, edoxaban. These new oral anticoagulants not recommended for patients with severe renal impairment. The new or we give 15 milligram rivaroxaban 15 milligram BD, 3 weeks. Apixaban 10 milligram, dabigatran 150 milligram, and 3 edoxaban. So don't give in renal impairment. Reperfusion treatment. Routine use of primary systemic thrombolysis not recommended in patients without shock or hypotension. Intermediate high risk PE. Close monitoring for early detection of hemodynamic decompression and timely initiation of rescue reperfusion therapy. Thrombolytic therapy for intermediate high risk patients and if clinical signs of hemodynamic decompression. Surgical embolectomy if anticipated. Bleeding thrombolectomy treatment high. Percutaneous catheter directed treatment considered in similar situations. Thanks a lot. Please revise this presentation 2 to 3 times before your exams. Thanks a lot.